David.
Thank you very much for inviting me to talk about some of the findings from the Euretina BEAVRS database. I've only got 7 minutes and 45 seconds, and that's not really enough time to do justice to data from over 14,000 attachments that are in the database. So I'm just going to talk about one specific question, which is, does early surgery make a difference in macular off retinal detachments? Now, the obvious way to test this would be an RCT, but I think it would be difficult to get regulatory approval for a trial that randomized patients to either immediate surgery or deliberately delayed surgery. And even if you did get approval, I think recruitment would be challenging, to say the least. So an alternative was to do collaborative prospective data collection using the Euretina database. Now, this is not an RCT. However, it does have some features of an RCT. The data collection is prospective. We have agreed definitions and criteria for inclusion, exclusion, and outcomes. However, because it is not randomized, it is vulnerable to bias and confounding. So 3 years ago, we published this study of over 2,000 eyes, looking at the probability of regaining 6/12 vision. Eyes were included if they were macular off at presentation and were successfully reattached by a single vitrectomy. We found that duration of detachment was important, that if your retina had been detached for 3 or 4 days, then you are only 2/3 as likely to regain 6/12 vision if compared to patients that were reattached within the first 72 hours. And there is now an emerging consensus that early surgery is beneficial. A recent meta-analysis concluded that surgery within the first 3 days probably had a better visual prognosis than surgery at 4 to 7 days. However, the authors of this meta-analysis added a caveat, which is that patients that are operated earlier tend to have a better preoperative vision, and the better preoperative vision may explain the better postoperative vision. And they have a point, because if you're operated in the first 72 hours of your detachment, then you're significantly less likely to have bad vision than patients that are operated later. And this matters, because if the better prognosis with early surgery is just due to better presenting vision, then if your vision is already poor, there's no rush to reattach the retina. However, if earlier surgery means a greater visual improvement, as well as better final vision, then prompt reattachment is advisable regardless of the presenting visual acuity. To answer this question, once again, we turn to the Euretina database. We looked at 4,500 detachments that were macular off and were reattached with a single vitrectomy. In this case, we were able to exclude all those with significant comorbidity. We had 2,700 with complete records, just over half improved by more than 1.3 logMAR units. And we did logistic regression on this data. We found 9 factors that influence postoperative visual acuity gain. One of the most significant was the preoperative vision. If your pre-op vision is better than 1.3 logMAR, it's very unlikely that you're going to improve by more than 1.3 logMAR. Duration, the effective duration, was small but unequivocal. In addition, the bigger the detachment is, the less likely you are to get good visual improvement. Your men do better than women, and face-down positioning seems to improve the prognosis. If you're pseudophakic, you're nearly twice as likely to improve by more than 1.3 logMAR units. Now, although the duration was statistically significant, the odds ratio is very close to 1, which implies that it may not be clinically important. However, this analysis underestimates the importance of duration because of outliers. What do I mean by that? The great majority of detachments are reattached within a week of losing vision. However, about 1 in 8 has a duration exceeding 3 weeks. And it seems unlikely that a difference between 21 days and 28 days has the same impact on prognosis as the difference between 0 and 7 days, although the interval is the same. So if we exclude those outliers and look just at detachments that are treated within a week of losing vision, then we see that the impact of duration is greater. The odds ratio has gone down from 0.98 to 0.87. This implies that during the first week that a retina is detached, for every additional day's duration, your chances of regaining more than 1.3 log-MAR units declines by 13%. If it's delayed by 2 days over a weekend, it goes down by 25%. Now, this study does have some limitations. It's an observational study, not a randomized trial. Patients may not be aware or may not know the duration of their detachment, and even those that know it, the recollection is often unreliable. In order to calculate the change in vision, the improvement in vision, we need to know accurately what the preoperative vision is. And we're not very good at that once people's vision is less than 1.3 log-MAR. For example, if your vision is worse than count fingers, but better than hand motions, we've got no really good way of collecting that data. Despite these limitations, I think we can conclude that early surgery is beneficial. You're more likely to regain 6/12 or better vision, and you're more likely to improve by more than 1.3 log-MAR units if the retina is reattached promptly. Is this making any difference in practice? Well, we've been talking about the importance of early surgery for macular off-detachments for about 5 years. So I divided the records into 2 equal cohorts according to whether they'd been operated before or after April 2018. And we can see that despite the pandemic, the duration of macular off-detachments has declined significantly. We're operating on them earlier. And this is translating into greater visual improvement. You're more likely to gain more than 1.3 log-MAR units if you've been operated since April 2018 compared to the cohort before that time. As always, I'd like to finish by thanking the members of Euretina and BEAVRS that have contributed the data to the database, without which we wouldn't have anything to present. Thank you very much.
David, thank you. It's great to see the database actually having an influence on our behavior, which that's one way of interpreting it. So thank you very much. John, did you have any comments on the methodology, which I'm sure David is delighted to hear about?
Yes, I mean, I think this is a very good example of, you've got a large collection of real cases. I think it's really not good enough for methodologists to sort of be sniffy and say, well, it's not randomized, therefore there's nothing to see here, let's move on. But nonetheless, as you say, there are challenges. And part of the attraction of a randomized trial is that if you do the randomized trial correctly, the analysis is relative, it's almost child's play, whereas for observational data, persuading yourself that you've properly adjusted for the differential reasons why people got various procedures and any kind of residual confounding is really, really tough. It's at the upper end of difficulty of statistical tasks. I think also, there was a fascinating couple of 30 seconds on the role of outliers. This requires really, really careful thought because often the apparently extreme values are the most informative, and a kind of crude analysis that just dispenses with the outliers may be quite misleading. I'm not suggesting that was the case here, but you need to be ultra critical. So the role of kind of sensitivity analyses, putting the outliers in and taking them out is really, really important. We were, of course, reminded that these were eyes and not necessarily individuals. That is a big issue running through most ophthalmological studies. What is the level of measurement that you're using? If you're looking at technical success, it might make perfect sense to have 2 measurements from an individual and then adjust for the correlation. But if, say, you're looking at a person's quality of life, does it make sense to have the study eye and the fellow eye contributing? These are important issues. And the last thing I'd say is please, if one thing that everybody goes away with, And don't talk about odds ratios and don't say that if you've got an odds ratio of 0.9, that's a 10% reduction in risk, because it isn't. Odds ratios, it kind of works when the diseases are rare, the events are rare, but odds ratios need really, really careful handling. They are the ratio of two ratios. And unfortunately, those simple interpretations of 10% reductions, they just don't compute. If you reduce the event from, say, a 50% probability to a 25% probability, I think everybody hopefully in the room would agree that's a halving of the risk. But the odds ratio for that particular pairing is 3, not 2. So it's not at the margins, this. Odds ratios are nasty, nasty things, and they can really, really trip you up. So, but fantastic study.
Thank you. Thank you very much for the explanation. We go on with the next speaker, Varun Chaudhary. He's going to speak about the systematic review and meta-analysis